Well, it is truly my pleasure to introduce Grand Rounds this morning. I have the honor, I cannot replace Dr. Sandy Clancy, who is the staff co-chair of the Family Advisory Council, but she was unable to be here this morning. So I'm trying to fill her shoes. So welcome to the 13th annual Family Advisory Council Grand Rounds. These Grand Rounds are truly unique in that they always highlight a partnership between family members and providers, whether in clinical settings or in terms of hospital systems. And this year will be no different. But before I move to our panel, let me remind you about the Family Council, which has been in existence at Mass General for Children since 1999 and has developed into an effective forum with hospital leadership and staff engagement with family members about their experiences and partner with them to promote high quality and family-centered care. Parent members have initiated hospital programs, participated in research, and this year produced mindfulness meditation videos in both English and Spanish for our patients, among many other innovations. Actually, I want to mention something very special that happened this past year, which is the first time that parent members participated in the Ether Dome Challenge, and 2 teams from our Family Advisory Council applied and actually won the challenge. The first project was entitled Support After Discharge, stems from parents' experiences with children with chronic conditions who are faced with a typical childhood illness after hours seeking advice about whether or not to go to the emergency department. The second, the Family Resource app, seeks to develop an app that would be available to family members who have an inpatient stay, providing a wide variety of information about such things as where to do laundry and what the discharge process will look like, what daily rounds are like, and where to get food after hours. Please join me in recognizing Miri Bar-Halpern, Ashley Conti, Erin Quinley for their work on the support after discharge, and Lynette Lavasco on the Family Resource app. They've been working diligently in developing this app with personnel from Healthcare Transformation Lab, the Center for Innovations in Care Delivery, and the Technology Strategy and Implementation Center at Mass General Hospital to find solutions that will result in better experiences in the care of our patients and their families. And we're honored to recognize their efforts. But now let's turn to today's Grand Rounds, which highlights once again how much parents and caregivers contribute to improvement efforts at the hospital and beyond. The title of today's rounds, do you mind if I switch it? Yes. Next. Yep, great. Is Family-Clinician Partnership to educate families affected by pediatric stroke or brain injury and their providers. Parent leaders Mara Yale and Gretchen Murphy will present together with Dr. Patricia Musolino and Brian Wishart. Together, this team leads the Pediatric Stroke and Brain Injury Education and Outreach Program at MGFC, which reaches families locally and around the world, including their providers. So please join me in welcoming this team.
Thank you. I'm here today. Well, we're here today to talk. We have 3 major learning objectives through the course of the work that we've been doing. One is to educate on a model of family education and leverage lessons learned to develop academic community collaborations in pediatric healthcare, to increase the understanding of unmet needs during development after pediatric stroke or brain injury, understand the value of community-based model, and to empower families, patients, providers together to improve the quality of life of the pediatric stroke thrivers. To give a little bit of background around my story, this is my son, Owen. Let me pause that for a second. I had Owen here at Mass General back in 2015. Very soon after he was born, he presented with seizures, which brought him into the NICU. And I think within 24 hours, we were told that he had been diagnosed with 3 strokes right around the time of birth. My husband and I are not in the medical field, so we had never heard of stroke happening in a child and an infant. So we were definitely in the dark and uncertain of our future. We met Dr. Musolino in the NICU at the time, and she has been instrumental in the care of our child, our son Owen, over the course of the last 8 years. And in so doing, in meeting with Dr. Musolino, I said, how can I help other parents like myself who were discharged from the NICU, did not know one family member nor one friend who had a child that had gone through what we had gone through. So we were kind of navigating in the dark for a light switch, having left the NICU. So I spent a lot of time on self-education, learning about the different modalities within the medical field and the power of the community. And I think this video shows, if you look, this is our son Owen. If you look at his right foot as he's running around a restaurant. We were out with friends. I noticed he was galloping and that right foot was really turned in and he was really dragging it. And at the time, I didn't know what to do. I obviously pulled out my phone, took a video. We were with early intervention at the time, which is when we left the NICU. We went in through early intervention. We had speech, occupational therapy, and physical therapy. But it was the first time that I saw in an environment with his peers that he looked different. So by taking this video, I shared this video with a physical therapist, and she helped me navigate to physiatry and orthotist. And now, very shortly after that video, he was fitted with an AFO on his leg. And if he wears pants today and runs, he does not have that foot turn in. You can't even tell that he has a brace on. He can keep up with his other 8-year-old friends. So getting therapies early on has been a huge benefit to Owen and his success. And the community that we've created, I may be the quarterback of his care, but I've got a ton of different doctors, therapists, educators that all are needed to maximize his success in this world. And that's my goal. And the Pediatric Stroke Clinic, once a year we go in, we see Dr. Musolino, Dr. Wishart, Dr. Grabowski, and it's like a 360-degree view of Owen and Owen's prognosis. They've provided letters to us that have gotten us the education that we need to help develop our IEP for his educational needs at school. So I can't say enough, and that's why I've been participating in this. And I have become educated myself, and I'm helping to educate other parents that are in similar situations that I've been.
So I'm gonna take it from here. And I usually, when I talk in rounds and stuff, you probably know me on the other hats, which is I can tell you how frequent the stroke is and what is the impact in life and what are the risk factors and what the labs and what the research, and I can quote 1,000 papers. That's not what I'm going to do today. You guys can go to any of the other talks to find this information. And I'm pretty active in all the departments in pediatrics, trying to spread the awareness about pediatric stroke and training the trainees and the next generations to really be able to care for these patients. But this is what really is happening in pediatric stroke. There is a presentation, an acute neurological deficit is not the same story in pediatrics. There are a lot of mimickers. There are other ways that kids can present, and it's not the classic face mnemonic of a speech, hemiparesis, sensory changes, and vision changes. And usually these patients have present in the NICU, neonatal ICU in this case, the emergency room, or the primary care physician. And this is a very common presentation for pediatric stroke. They usually go to you guys before they even access any emergency care. And it's very important. We kind of have protocols for emergency care at the pediatrics emergency rooms, at the general hospitals in the stroke departments. But what is really the most challenging, and I'm so glad to hear that the Etherdome Challenge was won by the people that did the advocacy for the discharge. This is the real roller coaster, and it's emotional, it's real, it's intellectual, and in the middle of all of this is your entire family. It's not just the kid that has a stroke, which means you have to find all the needs that need to be adapted, and sometimes it's feeding, like you're getting out of the NICU and your kid has all their needs of feeding and you're spending 16 hours of your awake time to feed the child. And this has a change in the whole dynamics of what you need and all the resources. And this is all the different ages where stroke can happen in pediatrics will have different impact in home, in work, in school. There is a really long checklist of what we tell parents in this discharge summary. So to the residents, give all your love at that discharge summary, because it's almost the only guide they have in writing to know where they need to go next for the next 6 months. So absolutely worth it to put the time that is required to guide them. But again, and I think reflected by this challenge that was just recently won, there is a lot more to do. And sometimes there is a genetic diagnosis, sometimes there is not. And I use this as a slide for both pediatric genetic causes of a stroke and non-genetic causes. But the time to what caused the stroke and all of that is happening at the same time that the kids are growing, they're thriving, they're going through school, they're going to try to start sports and build their own families. And then a lot of uncertainty to the years of young adulthood. And one of the things that we start with is we are MGH, MGV. That means that we span the entire life of an individual in care. So that's why we care about that transition too, is because we wanted to follow these patients and provide them with what are the next challenges. So after 18 years of med school, PhD, blah, 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 and pediatrics and neurology and critical care and stroke, I thought I was done. First day in clinic, guys, with Dr. Grabowski, who welcomed me to the Pediatric Stroke Clinic. That was the first one in the entire country, started by Dr. Bonanno and himself. And they welcomed me in the clinic as the first faculty, first day. And one of the parents from New Hampshire, she said, I don't know why I'm here. She was very upset throughout the whole encounter. We're taking forever. We're late. We are 3 people coming into the room, plus the students, plus trainees. And she basically said, everything I've gotten for my son, and the son was 11 years of age, I had to find it myself. I had to figure it out myself. And I was like, I don't know what you're talking about. I had 1 week of rehab in my entire training. So, and when she talked about PTOT community and this and that, I was like, did a lot of critical care. Does that help? And it wasn't what it was needed. It was very clear to me. So I pulled her aside after we finished the encounter without the kid in the room and asked her, could you make me a favor? Would you send me an email with everything that you're talking about? I do want to know. And from there, I recruited a Harvard medical student that wanted to do an advocacy project in the summer. And she mapped and interviewed parents in our clinic to find what resources they found helpful. And then we started learning that there were a lot of practices that are not MGB, that are not at Spalding, that are out there in the clinic where they live, that were really making a difference in their rehab and their development and their learning. So this was a lot bigger problem. And it was way beyond where we are mostly focused, which is diagnosing, getting to the risk factors, trying to prevent another stroke, neuroprotection, which is in the acute, that's my red part of the lights here, to all the way to the family and community, which is what really should inform the research that is happening when we try to improve outcomes. And I'm gonna put this out there to myself, who is a person that's trying to do gene therapy. What really matters is what matters to the patients and the community. So if you think about why and what is the time that we're talking about in the life of an individual, your acute care, and I put 0.01, this is probably 0.00001 of your waking hours, okay? The amount of time that in your life or in your childhood that you spend in the ICU, no offense to our PQ colleagues here, is very teeny tiny, is critical, as we know. Then if you think about after you suffer brain injury, there is a change in your equation of what time is spent and how the families had to get to access these services. And these are some of the classic ones. And Gretchen was telling us about this myriad of early interventions plus all these other services her son was in need of. And in a waking week, this could take up to 10% of the lives of kids. This 10% is not in the life of a neurotypical child, okay? This is what Google says we spend in school. from 0 and 18 years of age of our waking hours. 15% is formal education. Therefore, 75% of what you're doing to impact the development, the recovery, the learning, and the happiness of these children is at home and with the community. So as healthcare providers, I take it as unacceptable that we don't know how to impact that 75%. Okay. And I do know from being an intensivist how critical it is that we do right when we are in the hospital, how critical it is that we have the rehab access, and a great education system. No one have to say anything about it, but I still think we're having massive unmet need. So one of the things that was very clear is I did not have the knowledge, and I say this over and over. The knowledge was in front of the room, not in front of the room, was in the room. So when I met with a few of the parents that we were interviewing to get these resources, it was clear that we needed to do a survey. So we get an IRB, we start a survey, we try to look at what are the resources. And that's where Mara took the lead and Gretchen followed her, and then a bunch of other parents with different skills, and in fact, participating in many different other organizations that do advocacy very actively and provide real services to these families. They started to come together, and we just provided space for them to work. And this week have like our monthly meetings, we have our quarter meetings with a much larger parent community group that is also encompassing people outside the Boston area. It became very clear that we could not do everything with MGB alone because we have conflict of interest for all the private practices. We couldn't put it in a website. At the same time, I was trying to see if we can understand the genetics of disease. So I said, okay, I don't have 2-3 lives. There's only one. So let's do an advocacy group. And we funded this nonprofit, Young Genetic Stroke Alliance. And Mara will talk a little bit more on what lives in Young Stroke Genetic Alliance. So I'm going to switch gears and kind of like remind everybody what pediatric and perinatal stroke are and why, what are some of the features that are different. And I will go back to what I'm learning as I work with the families in every slide. So one of the important things is perinatal stroke. The first week of life is the week of highest risk for a stroke in your entire life. Okay, we tend to think, oh, stroke is after we are like 65, 75. No, the highest week risk is the first week of life. Perinatal stroke is as frequent as stroke in the young, and it all happens in the first 3 days of life. That's why we're doing so much research trying to understand the imaging, the outcomes, and what are the risk factors together with the team at the Pediatric Stroke Clinic and many others at MGH and the Brigham. One of the factors that is in place and is unique to perinatal stroke is that the fetal circulation has a connection with the mom's placenta, and we have a maternal and a fetal side. And as the maternal side is clotting to separate, the fetal side remains open and without clots because a clot in the placenta will travel directly through the umbilical vein to the right side of the heart, patent foraminal, which is foraminal at this point, straight up into the left side, carotid's head. And that's why perinatal stroke is so frequent. And one of the most common causes is that any stressor for the baby, any perinatal depression, any chorioamnionitis, any factor in the mom, hypertension, diabetes, will tilt that clotting, bleeding balance that is so unique at the time of birth between mom and the baby towards clot. And when that happens, you get these ischemic strokes. And when you have the opposite, you can have hemorrhagic stroke. And that patent foraminal is supposed to close. That's the other thing that is very common in pediatric strokes, congenital heart disease, not only from non-closure of a patent foraminal, which is common in the population, but much larger congenital heart disease. And beyond congenital heart disease, patent foraminal, paradoxical stroke is another very common cause of a stroke in the young, in primarily childhood. So I know that you guys think about the brain all day long and that the arteries and the veins are in your mind, but remember, they're not paired like in the rest of the body. And that gives you importance in what disease happens when you have a clot in the arteries versus when you have a clot in the veins. So there are different types of stroke. We call it arterial ischemic if you stop flowing with an artery, venous thrombosis if you clot in a vein, and hemorrhagic if you rupture a vessel. So arterial ischemic stroke is the most common one in pediatric stroke, and is definitely the most common one in perinatal stroke. So a clot sits in a vessel, occludes the blood flow to an area of the brain. Usually we call that the core of the injury, and it ends up suffering the most. We know there is a big area at risk, and that's what all the acute care that 0.01% goes after is to really try to reopen, recanalize, or preserve the collaterals to salvage the penumbra, the tissue at risk. And there is an interplay between platelets and thrombin. So you really need, in pediatric stroke, there's not such a thing as a neurology service without a hematologist on your right hand. And I'm doing my left here. And the reason is you gotta adjust in development and liver metabolism. What are your drugs? What is your platelet? What is your thrombin? And what can you offer to this child? If your clot is now being formed in the venous sinuses of the dura, then you have a backlog of pressure. Usually this can lead to two things: ischemia, so because there is not effective blood flow, and hemorrhage if the pressure continues to go. And that's one of the few reasons why we treat this with a blood thinner. Even though it's a clot and there is a risk of hemorrhage, we still treat with heparin in sinus thrombosis, both in newborns and in children. Another type of stroke is hemorrhagic. And that is pretty self-explanatory. A vessel has a tear that leads to bleeding and extravasation of blood directly into the brain parenchyma. And in the kids, this venous thrombosis or medullary vein thrombosis can also lead to small hemorrhages. So those are the classic injury that we get from medullary vein thrombosis, very common in hypoxic ischemic encephalopathy. So I'm going to refer to this brain and the localization, and Dr. Wishart is going to go even further into it, just to note the importance that you start trying to understand what happens in acute. Acute is the only time we're going to have imaging in pediatric stroke. Most of these patients do not get a follow-up scan 2, 3, 10 years later. It's not indicated. So you're going to have to guide all your care from that perinatal MRI or that MRI when the kid was having the stroke. And so one important thing is to learn a little bit about how big and where is the stroke. It's not just the location of the stroke. It's very important to understand what areas on the network that the brain has to function could be altered. So we think about hubs, and if you're thinking about Facebook, the ones that have a lot of visitors are going to be more critical and are going to affect other functions that you are not necessarily thinking of as a classic stroke outcomes. So one thing that I wanted to point, this is a middle cerebral artery stroke, both arteries, the superior and inferior divisions, and you can see almost like 2/3 of the left hemisphere had been affected. I have over and over and over seen this, and we're still studying why is it that the tissue outcome is completely different between two kids. And this is why we do have to do a lot of understanding in the genetics, in the factors that lead to healing and neuroprotection to determine why a patient can end up with encephalomalacia and a cyst, and others have just a scar and a small tissue loss. And when the acute injury is the same. And this is what I'm telling you we are missing. We do not have routinely follow-up MRIs on these patients. So when you are dealing with a patient and you go back to their chart and look at the MRI, remember, do not talk about prognosis with just the image that you have in acute. We know nothing about how this kid is going to do. We do know the areas at risk, and that's the most important thing to really think through. So injury, healing, and learning is way more than the brain. And I'm just depicting here that there's not just neurons, there is oligodendrocytes, astrocytes, there is immune cells, there is vascular milieu, there is the ependyma. There are so many things that are in the biological side, but what is so important is that the brain does not learn in vacuum. It learns only by environment. And the way that we think about the brain is that it has a map for everything. And you can see here the primary and associative cortices and the different functions and where hearing is and feeling is and motor function. And it is important to know this basic anatomy, even if the patient is going to do different degrees of outcome in those areas and domains. And I give you an example. The sensory is usually very well recovered. Patients have very little sensory deficits, even though they took down the primary sensory cortex. The motor is a different story. And it's important to know what areas are affected because it would allow you to also monitor and decide when you need to do certain assessments and do the interventions. And these things are very funny if you just plot them on a 3D. We have a lot of more neurons to move our fingers and our tongue than to really move our arms and our back. That means that you have one neuron that innervates many, many other muscles. So I wanted to give an example on how do we learn from patients while thinking about our neuroanatomy and our neurology. If you think about the cortical motor pathways, there is an upper motor neuron, and everybody knows this, it crosses in the medulla and it gives you connection to the lower motor neuron in green here. That's supposed to go to the muscle and make the voluntary movement that you want. Guess what? That lower motor neuron is also at the use and mercy of this sensory neuron from the muscle, which is there on purpose to give you muscle tone. So every time gravity stretches the muscle or your neurologist with a hammer, you get a contraction of that motor neuron that keeps the muscle from getting flaccid and it prevents you from falling to the ground. So this is anti-gravitatory myotatic reflex activation. When you don't have the boss, the upper motor neuron, this could be released, and that is what leads to a spasticity. Are we doing okay? Yeah. So I wanted to cue people here, and it will be, what side of the brain do you think the 7-week-old baby has affected? So I see a hand moving on the right with a lot of finger, and it's getting to the mouth, and it's being explored. And that's also because you remember the homunculus, the mouth and the hand map together. That's the way the brain learns during early infancy, is by doing sensory and motor. So any guesses what side of the brain could have been affected? It's very hard. And I want that answer to be still there with us. Okay? You're not a bad pediatrician or neurologist if you cannot tell what the kid's injury is. You're not Gretchen Murphy with 43 years or 35 years of clinical examinations. This patient has an injury on the left side of the brain. And if you look at that right hand, come on, that looks like a total fine baby, beautiful hand. So I'm trying to say this because don't label patients that are normal, neurotypical development just by the first couple of exams in life, and keep an eye on your patients. They're going to teach you a lot more as they develop, because a lot of the functions will emerge later in life. So here we have a 4-month-old, the same baby, and you can now tell from this picture that there is something asymmetric. There is one hand that is fisted, one hand that is open. That hand that is fisted has this myotatic reflex released and hyperexciting, and it has what we call a spasticity. So, and you can see here when gravity is acting against this big head, and this baby has to keep head and chest up to not suffocate. And this is to the tummy time, tummy time, tummy time. Not really. Okay, if it's distressful to the kid, that's not the way they're going to learn. And if they have a difficulty, you can see how that right hand gets really fisted and is not able to catch the toy. It's much more difficult to explore the environment. That is going to jeopardize your learning and ability to develop that right side of the body. Towards this video, where you can see the kid is on the side, the right hand is going towards gravity, not against gravity, okay, or not the whole body against gravity. So there's no activation of tone. And you can see a lot more repertoire of movement of these fingers on that little corner of the pillow, as the baby found something that is also interesting to the baby, okay? So it's very important that the learning happens in context to something that the child is interested. And again, going back to the 75% of the time at home in the community, if we do not teach parents about these concepts and how can they facilitate learning, we're missing a big opportunity to allow this kid to develop better. And here I'm giving you an example of a multisensorial. And also you notice the kid is on their back. So that means there's no gravity to fight. And now we have a shadow of the hand. So there is a visual stimulus. There's mirror neurons in the cortex, the first one that we have in action as babies, to smile and do things that our parents are doing. And now the next hand comes into place. And I now have sensory tactile information mapping that hand. And it's a whole different experience that this hand is having a chance to have. Put the kid on tummy time and tell the parents they have to do this 3 hours a day, which is a classic recommendation of neurologists and pediatricians, that you will be inhibiting this experience. Not only that, the kid is going to be pissed off. The parents are going to feel frustrated and they think they're doing something wrong. The truth is they are, but we told them that. Okay. So I'm bringing this very bluntly just to start recognizing that there are other things that we need to hear parents tell us, because this is a mother telling daycare what kind of things can be done to enhance the experience of right side that is affected in this child. And the same goes on for language. And I use this one to just say, you got a receptive part of language, an expressive part of language, a connection between the two. And guess what? They're under two different vessels. And that's why vascular territories for the stroke neurologists are important. They can also tell you where to map and expect certain deficits. And this is in a very short snapshot. And I hope you can hear some of this. And I'm gonna do a little bit of. You have what it is on the title, so I don't speak. You just kind of. And then we have purposeful communication. It's doing it towards the person that is in front of the kid. And through language. You notice that I picked one that doesn't have a lot of words. This is language, okay? He's naming things. He has monosyllables for things. And you can see the kid repeating what the parent is saying. You can see how happy is this interaction. And that's the best way to learn a language. I don't know if you ever tried to learn a second language, but we try to learn second languages with books, so it's very boring.
Ice cream.
Why should you stop eating ice cream?
Because my belly says that.
How much ice cream did you eat, Birdie?
So long.
So long.
So
ice
long.
Cream.
And I picked it on purpose. There are neurotypical kids here and the kids that have had a stroke. And the reason why I do it is because the sequences still follow, regardless of having had or not brain injury. You do have to go through the different phases. And this is just to remind ourselves that communication is way more than words. And you can have incredible interactions between the kids. And I do it on purpose, this busy, just to get ourselves to relax a little bit about what is the kid, what it should be doing, and start trying to watch them and observe what they're doing. And this is something that I've learned from the families working with us, more than anyone in a lot of amazing therapists that we have. But as clinicians, we don't spend a lot of time with therapists. We don't spend time with a speech therapist or with the occupational therapist, or even with the rehab doctors, that we have the luxury of having one in our pediatric stroke clinic. So this is the take-home message. Maximizing brain development and learning requires a multimodal, integrative experience. And that means even the affect has to be important, has been studied extensively. If you don't have a relationship and you have affect with a person that you're trying to work with, you do not learn the same way. And supporting this process can make the highest impact in the acquisition of those milestones, in the learning, and in the ability to have also a very good self-esteem about themselves. And something that sometimes we kind of miss the target when we're thinking about and concentrating on what is missing, is that we're not seeing the abilities that the kid has to even learn their own way on their own path. So with this, I'm going to pass it on to Dr. Wishart, who's going to tell us more on how the rehabilitation world can come into place.
Thank you. So I think this slide is a great intro to what I'd like to talk about. You know, when we think about development, it really is a sequence. And we learn the Denver scales and we learn all the different things. But I think the important part here is that this is an iterative process, right? Children are learning one motion, one skill, one developmental milestone that leads to the next. And these things can be thought of on curves, and we can talk about the different developmental curves, but I really like the idea of this sequence as things are going through. And I think when we're learning, especially as residents, as medical students, we learn them like this. We learn our gross motor, we learn our fine motor sequence, we learn our language sequence, And we don't recognize that realistically, we can kind of take away all those specifics, especially when we're talking about kids with disabilities, and realize that they're all together. These are not in a vacuum. We're not doing this separately. It's really important that we're sitting before we're feeding, before we start to use that pincer grasp and that fine motor, and all these things are important. And the reality is that there may be a difference, right? If we've had a perinatal stroke, we may be seeing a difference in how these kids' gross motor is functioning, or how the fine motor is functioning, but the language and the social aspect is back where it should be, and they're developing appropriately. We may have a stroke later on, and the goal there, right? So we're developing the whole child. We really want to think about this and try to help with that habilitation, right? We talk about rehabilitation, that's part of my specialty name, but sometimes kids have not learned those skills in the past, and we're putting this learning onto a developmental sequence and trying to get them to achieve these skills where there are impairments that are making it challenging as they're going through this. And how do we enhance that? And how do we make sure that one domain isn't impairing or impeding a second domain, and make sure that they're developing those skills as they're going through? The reality is that they don't always happen right at birth. And sometimes a lot of times we have children that have had a deficit or had a stroke that's later on. They've started to develop, they've learned things on a typical curve, and then they've had an impairment, they've had a stroke when they're 2 or when they're 6 months or when they're 9 months. And how do we end up working with them to enhance that quality of life, enhance that functional ability on top of that developmental sequence, right? There's parts of this that we need to bring them back up and get them back up to that curve that they were doing, but also maybe we're not going to be able to. Maybe that sequence and maybe that curve is going to be different after we've moved through this. And how do we think about that? What are we going to do to help them develop in their fine motor, or help them develop in their social interactions and their social development when they have a deficit in their mobility, right? When we're learning to crawl, we get led because they're all over the place. They're crawling all over the place. They're exploring things. They're learning lots of different stuff. And so this is where we start to think about recovery versus accommodation. Sometimes we're not able to help them recover in that same pattern or that same speed that we would on a typical developing child. And how do we think about that? Maybe we do want to utilize some things that are able to take that tone out, take away that gravity and impairment that's going to make swallowing, that's going to make reaching out really difficult, and give them that support. Or, I love this, it's really hard to get approved by insurance, but the rabbit stander, where they're able to stand, be up with their peers, be at that level, but be mobile, right? They're not in that standard that just locks them in. And these types of things aren't appropriate for every child. There are kids that we really want to make sure that we're just recovering and giving them that strength and giving them that skill back. But there are certainly other kids that maybe aren't going to develop that skill on a timely basis, and we're going to start thinking about impairing their other domains. And so that's part of the thing that we're thinking about on the medical side. I think the challenge is, what are our goals? And I think about this all the time. This is our goal. This is that same child that was running around with that impairment of his right foot at the beginning of the slideshow, out playing golf with his dad. And yes, he has an accommodation. Yes, he has that brace, but he's out doing the things that are important, right? Walking is great, but our goal for walking is so you can interact, so you can go and have relationships, so you can go play golf with your dad and that kind of stuff. And this is sort of what I think we should be thinking about as we're going through all of these discussions of, do we want a wheelchair? Do we want a brace? Do we want other stuff like that? Why? What is the purpose for it? And that is crucial to have that conversation with the families. So we talked about what kind of deficits. Stroke is really interesting. It's exciting, I think, at times to take care of, because it can be huge breadth of deficits, huge breadth of presentations. And it's all related to location and recovery, right? We don't even know when we have that first injury what it's going to look like on the back end, but we have a sense. And depending on where we have that injury, can have a whole slew of different deficits that come out. And that breadth is really challenging at times as a clinician to have the expertise on how to care for these kids. I'm pretty good at motor stuff, at tone management. When it comes to executive function deficits, when it comes to speech deficits, when it comes to cortical visual impairments, not as great. That wasn't where my focus was trained. I'm learning more, I'm working with things, but we really need a community. And you can imagine, as a clinician who has that background, when you struggle with that, how hard it is for families then to take that expertise and know where to go, who to ask, who's going to be the leader in this setting. And so, let's see. What we've tried to do is think about the different spots in this education series, which we're going to talk about more, but the different areas that we're thinking about as we're going through this. So if they have a motor impairment, what types of things are we thinking about? Is it, adaptive sports? Is it activity? Is it when kids don't want to go to therapy anymore and it's in middle school? And what can we do to get them into the community, working on these skills in a way that's also socially engaging, that's also fun, and that they're going to want to continue and take that on for themselves? If their gait is off and they're having difficulty, what do we think about bracing? When we have fine motor difficulties and a hemiplegia, the CIMT, the constraint-induced movement therapy. We've had a lot of different things, from CP soccer panels and swimming, the adaptive play, which is, at its most simple, video games, but can go elsewhere. All of this stuff we're trying to bring to the families, because at the end of the day, each kid is going to be very different. And as much expertise as that I can develop, I'm utilizing my community within the medical field, and we need to bring that to the families too, and make sure they have that expertise and they have that community as well that they can reach out to. When we think about other ones, aphasias and field cuts, we've looked at visual processing. We've asked neurologists to come to talk to the families about their perspective and how they've gone through things. We've worked with some of the specialists within, research and brought that to them. We've looked at different areas such as speech and swallow and auditory processing and tried to bring that stuff to the family. And all of these things are full 2-hour lectures on their own. And so it's impossible to do that in the clinic, right? And that's where we really need to make sure that we're bringing these things to the families and to the community and making it theirs so they can take that ownership. And, at the end of the day, there's even more, right? These are sort of the more nebulous aspects: executive functioning, mental health, talking to your kids about their medical condition. How do we, we talk about that transition and that transfer as kids get into young adulthood, but there's a transition when they're younger too, when they're starting to learn about all this and everything. And so we've tried to bring all of these things from school and everything else to the community, to the parents, and try to take that expertise that we use consults for and we reach out to colleagues for, and bring that into one way that we can actually, make it digestible and useful to the families. So I'm going to pass over to Mara.
Thanks. So this is maybe one day after I had my second child, who was the baby featured in the videos Patty shared. We've come a long way since I first shared those videos with Patty, I think at a coffee shop. So you'll see that. So healthy, full term, baby, 9 pounds, 5 ounces, excellent APGAR scores. I had attempted a VBAC, but it was a second cesarean birth. Then at 48 hours old, I had sent my baby to the nursery to rest. I'm a single mom. My sister, who'd been with me through the birth, was home taking care of my 2-year-old. The hospital pediatrician woke me and said, "Your baby's having seizure activity." My kids were born at Mount Auburn Hospital across the river, and I had to send my baby alone to Mass General. I was standing for multiple hours, 2 days post C-section, as I watched my baby get transported. These are my kids now. They're 16 and almost 14. Echo is on the left in the turquoise. Will be graduating from 8th grade and turning 14 next month. Both kids play soccer and ice hockey and are really phenomenal human beings. So I could share any of a million moments of getting to this point, but I'm actually choosing one moment just before and just after Echo turned 4 years old. So it shows Echo's character, but it also shows their hemiplegia. So Echo's incredibly determined and set about learning to use the monkey bars. And so in this first clip, you can see their slower right hand. And you can also see that they recognize when they can't go any further. And they let go and fall safely to the ground. So my kids were not bubble wrapped. They had healthy, active childhoods. You can see bruises on their legs and arms from active play. 4 months later, and our daycare had a lower monkey bar, so Echo was practicing every weekday. And we're back at the park near our house. And Echo says, Mom, I can do the whole thing. Same t-shirt, don't be confused. There's still a lag with the right hand, but there's way more confidence. And they're using momentum and they're patient with themselves. Okay, so the educational series. So when we started in the pediatric stroke clinic, we were followed both by neurology and the stroke clinic, and it evolved to every year or every 2 years. We didn't meet Dr. Musolino till Echo was 6. And at that time, there was something different. She listened in a different way and actually was interested in the blog that I had kept and in videos like those that you've seen. And that evolved to our first educational events, which were in 2019. And I would say these were primarily conferences for the parents. We had childcare and play next door for the kids in the Simches Research Center. And they were wonderful events. And we had 2 in 2019, and we were on track to have a 3rd in April of 2020. Which of course didn't happen. By October of 2020, we pivoted and said we're going online. And we've run monthly events ever since during each academic year, running 9 to 10 events. Our top video on YouTube has now reached 1,000 views. We have more than 40 sessions up on our website. And we, as you'll see, have speakers from many, many different organizations that we partner with. So how do we reach families? We start with the stroke clinic here, but we also need social media. And obviously the clinicians can't reach the families on social media. So I spend a lot of time pushing things out, partnering with others to push things out. And we partner with the International Alliance for Pediatric Stroke, and they also reach a broader international audience. Many of these families are in geographically isolated places where they may not even have a neurologist or a physiatrist. So I'm going to click quickly through these slides. Brian shared some of the titles in a better view, but each topic is very specific and the breadth of topics is huge. Okay, so just as Brian shared developmental trajectories for individual children, we have a developmental trajectory for the growth of our program. We started with these partners, but mostly with in-house expertise, all the therapy centers within Mass General and Spalding. And as time evolved, there's a timeline across the bottom, we've added more and more partners. And I'm not representing any partners twice or 3 times, but these relationships are now multi-year relationships, propagating to research and then back to inform the clinical care. Recently, so all of this for me was and remains a labor of love and was primarily volunteer work until January 2022, when Patty found some grant funds to hire me part-time. So I am now an employee of Mass General, and as of March, we've started to come back into the clinic. So we have individual QR codes to specific topics. And I have the privilege of listening to clinic visits. And usually I can discern that there's 1 or 2 topics that would be most relevant to a family at any one moment in time. So I introduced them to our educational series. after the clinic visit. And if we have other events, we share that with them. Today, for example, there's an info session for families interested in iAcquire, which is the first phase 3 clinical trial for pediatric rehabilitation habilitation. It's constraint-induced movement therapy. When Echo, my child, was 12 months old and their hand was tightly fisted and the PT wanted me to pull the thumb out, I went to the literature and said, I don't want to do that. And I found a parent who told me how to do constraint-induced movement therapy. But I had more resources than most families do. Now there's a phase 3 clinical trial for 8 to 36-month-old infants and toddlers to understand the appropriate dose. Is it 3 hours a day or 6 hours a day? And this is a 4-week in-home intensive, 5 days a week. So 20 days of in-home therapy, 3 hours or 6 hours a day. And the trial, we're actively recruiting. We're at 66% of the 240 randomized children for this trial. And I co-chair the parent council for the trial. So these things are very circular, the different roles that I wear and how they in fact influence research as well as clinical care. And the rest of the slideshow is sort of a celebration of an event we just hosted on Saturday. So 3 days ago, we hosted our second annual Play to Thrive event. Last spring, we were feeling like everyone needs to come together in person again. We've been doing this great work online. Let's do something to play. So we used the space outside of Spalding, right by the waterfront. And this is a map of our stations this year. And we gave kids a passport so they could get stamps at each station. And it's a tour of the station. So Perkins, School for the Blind, and Mass Ioneer have been early partners with us. Lacey is someone I also know from the Mass General for Children Family Advisory Council and is on a mission for earlier diagnosis of cortical visual impairment. So I've introduced her to this team, and now we're trying to figure out how we can add that to clinic visits to discern when a child might need screening. This is a control versus CVI on this toolbox, toy box test. You're trying to find the blue car as quickly as possible. You can see that the child with CVI has a harder time finding the car in the noise of the cluttered toy box. This is research from the lab of Lotfi Merbet at Mass Ioneer. And we're consenting kids in the pediatric stroke clinic to participate in research like this. And then people are finding us. So we had the whole event planned, and then someone I had met through the iAcquire work I do contacted me and said, and we met for an hour, and she is at UConn, Suda, and she is running this clinical trial for 3 to 8-year-olds, letting them ride on these cars that are controlled either by 2 joysticks or 1 joystick. It's a pilot grant from the National Pediatric Rehabilitation Resource Center, See Progress. And she said, I said, oh, great, we'll put you on our educational series for next fall. And she's like, no, can I come to the event in May? I'll bring the cars. Well, you can see that the kids thought those cars were pretty awesome. There also are teaching opportunities. So this is Jennifer Packard, who's an OT from Spalding and also works with Spalding Adaptive Sports Centers, orienting the large number of PT student volunteers that we had at the event. So she's training them on how to fit the kids for these adaptive bikes. We had this huge team of volunteers, which really individualizes the experience for kids at this event. I counted last night, I think we had 103 people at the event. You can see there's the one-on-one coaching on the bike. Team Impact's another new partner that matches college sports teams with children with serious illness or disabilities. This is a great community resource because there are so many college sports teams. Team Impact has built a team of social workers and case managers. They match make. You find social emotional goals for your child. My child is matched with the Brown women's ice hockey team, which is where I graduated from as an undergrad and played ice hockey. So it's quite a thrill to get to be a member of a team and it's a 2-year, really in-depth relationship. We had CP soccer, which is another research avenue. I'm gonna turn the video on. So we got to go to the New England Revolution game.
Thank you, CP Soccer, for making the sport accessible to all and allowing everyone to play the beautiful game.
So you can imagine the thrill for the kids to be on the field during the game, recognized like that. And we're very excited to be taking that into research. So we're now with this team partnering with a team from Columbia University that's had a research camp in Queens, New York, 2 prior summers, and we're now partnering. Brian just got a grant from Spalding to support travel and lodging for kids from New England to attend this day camp. You saw Team Impact enabled play allows accessible gaming. So the little boy on the left is steering Mario Kart with head gestures. And the girl on the right is learning voice commands to control a video game. Joe Walsh is a longtime friend of our program from Adaptive Sports New England, helping match and mentor even school coaches so that they can adapt sports to include all children. And we take a little parade around Menino Park, really like what Patty was saying, daily life, bubbles, scooters, bikes. And the volunteers help make it really special for the kids. And we just want to thank you for your interest. I think we have like 2 minutes for questions, but I'm happy to stay.
Go ahead.
Yeah, so that's great. That's a great success story. I think resource identification is just this ongoing problem. It reminds me of a whack-a-mole game that right when you think you have it under control, a coordinator leaves or financial policy changes or whatever. And the issues that you've showed us today are shared by people with autism or traumatic brain injury or neurosurgical tumor resection, infections, a million other things, neuromuscular diseases. Do you have any sort of guidance overall? I mean, it sounds like Mara's position is paid for by a grant, but in terms of finding and holding on to that ability to identify resources.
I can try to answer that. I always think feasibility needs to be first demonstrated, and then the value and what comes back to decrease the cost needs to be shown. So we have surveys and we're trying to capture that because I want to make this the pitch to the hospital that these positions, we call it patient navigator, coordinators, are really making a huge difference. Mostly if they're people like Mara, Gretchen, and the people working with us, which have the capacity to go beyond the institution. And I think that link is something that the hospital doesn't have it in the mission, okay? But I think we have to realize, again, the 75% of the impact is going to happen somewhere else, not here in our doors and building. And it doesn't go against our mission. So I think the short answer is so far, it will continue to be grant funding and philanthropy. This is self-sustained in a way because every family that participates in anything gets the chance to donate. And most families go for a $25 donation. And that over the events of the year, pretty much bring a pretty solid $30,000, $40,000 total between the events, the fundraising. We do have parents that are dedicated to the fundraising too in this group. Claudia Newton has taken the lead has done the MacArthur. So we also use anything in development in MGH that is available. McCourt, sorry. McCourt ran, by the way, this weekend, next weekend?
June 4th.
June 4th, that we have a team for PD stroke educational series, and that's how we are trying to sustain it. So I always think it's going to be a three-way: philanthropy, grants from research that will keep this going, because it's important to understand the research aspects of it. And then the other one is the hospital coming in to match us. We're getting there.
I wish we had more time. This has been just a brilliant example of family and clinician partnership, and a model for us all across all kinds of important efforts at MGFC and beyond our walls. So I really want to thank you not only for this beautiful presentation today, but for all that you do for our families and children and ourselves as we learn from one another. Thank you so much, and look forward to seeing how everything continues to blossom under your guidance.
Thank you.